head and neck cancer. Welcome to Professor Egashira.
Thank you for introducing me. Good morning, everyone. I'd like to express my deep appreciation to the member of organizing committee of this symposium. Now, I present my paper entitled "The Therapeutic Strategy for Esophageal Cancer with Synchronous Head and Neck Cancer: Treatment of Synchronous Oral Cancer plus Esophageal Cancer."
It's okay.
In my presentation, I'm going to talk about two topics. First, standard treatment for resectable advanced esophageal cancer in Japan. The second, therapeutic strategy for synchronous advanced esophageal and oral cancer, case number 1. The first topic is standard treatment for resectable advanced esophageal cancer in Japan. Could you please widen?
被网络弄到。Sorry. Okay. Is that okay?
Could you please widen?
Sorry.
Thank you.
Okay.
Sorry. The clinical trial, clinical study, Jacob. The clinical study Jacob 9204, which was conducted by the Japan Clinical Oncology Group, compared surgery followed by 2 courses of chemotherapy using cisplatin and 5-FU with surgery alone. The eligibility criteria is squamous cell carcinoma and pathologically proven stage 2A, 3, and 4 due to distant lymph node metastasis only, and so on. After the assessment of pathologic finding in the resected specimen, patients were randomly assigned to 2 arms, this surgery alone and surgery followed by chemotherapy. The primary endpoint was disease-free survival, and the secondary endpoint was overall survival and toxicities. Okay. From this trial, Jacob 9204, the 5-year disease-free survival was 45% in surgery alone group. On the other hand, that was 55% in surgery plus chemotherapy group. The disease-free survival in the surgery plus chemotherapy arm was superior to that with surgery alone, with statistical significance. In addition, toxicity during chemotherapy was tolerable. Then the next clinical study, Jacob 9907, was conducted. In this study, surgery followed by chemotherapy using the same regimen, same drug, cisplatin and 5-FU, were compared with neoadjuvant chemotherapy using cisplatin and 5-FU, followed by surgery. The eligibility criteria, SCC, and clinical stage 2 and 3, and so on. So this means resectable advanced esophageal cancer. The primary endpoint was progression-free survival. The secondary endpoint were overall survival, adverse events, and RZ rate. From the result of this clinical trial, Jacob 9907, overall survival of neoadjuvant chemotherapy was superior to that of post-operative adjuvant chemotherapy arm. The 5-year overall survival is 43% in the adjuvant group. On the other hand, 55% in neoadjuvant chemotherapy group. These results showed statistical significance. There were no remarkable differences between two groups in terms of post-operative complications other than renal failure. From these studies, the standard therapy for resectable advanced esophageal cancer is now neoadjuvant therapy, especially neoadjuvant chemotherapy, followed by surgery in Japan. This is guideline for the diagnosis and treatment for esophageal cancer in Japan. As you know, on the other hand, in Western countries, preoperative chemoradiotherapy is a standard treatment. By NCCN guideline for esophageal and esophagogastric junction cancers, preoperative chemoradiotherapy followed by surgery is recommended for resectable advanced esophageal squamous cell carcinoma. One of the papers which became the evidence for this guideline is cross trial. The cross trial compared surgery alone with neoadjuvant weekly chemotherapy, weekly paclitaxel, cisplatin, and concurrent radiation. The dose of 41 gray. The median overall survival was 24 months in surgery group and 49 months for neoadjuvant chemotherapy group. The difference between surgery alone arm and neoadjuvant chemoradiotherapy group was statistically significant. In this trial, 75% were adenocarcinoma and only 25% were squamous cell carcinoma. But in subgroup analysis, superior of neoadjuvant chemoradiotherapy was observed in both histologic type, adenocarcinoma and squamous cell carcinoma. Actually, this might be not suitable, but when we compare the overall survival rate between cross trial and Jacob 9907 trial. So this cross trial, the neoadjuvant chemoradiotherapy, and Jacob 99, the neoadjuvant chemotherapy. When we focused on the squamous cell carcinoma, overall survival was similar. So now, as mentioned before, neoadjuvant chemotherapy is a standard therapy for advanced resectable esophageal cancer in Japan. So it means this is now standard therapy for advanced resectable esophageal cancer in Japan. However, because the reported therapeutic outcome is not inferior to that of neoadjuvant chemoradiotherapy. However, we sometimes feel that neoadjuvant chemotherapy by cisplatin and 5-FU is less powerful, especially for the patient with stage 3 disease. And now we are doing a phase 3 trial that compares neoadjuvant chemotherapy using cisplatin and 5-FU and neoadjuvant chemotherapy using docetaxel, cisplatin, 5-FU, and neoadjuvant chemoradiotherapy using cisplatin, 5-FU, and 41 gray radiation, followed by surgery. This trial named Jacob 1109 next trial. This trial will examine and compare the efficacy of bimodality or trimodality therapy for esophageal squamous cell carcinoma. In other words, which is more important, local control or systemic control? Then I move to the second topic, therapeutic strategy for synchronous advanced esophageal and oral cancer, case number 1. The case number 1 is a 44 years old male who has synchronous left lung cancer T2N1M0 and thoracic esophageal cancer T2N2M0. The performance status is 1. Precisely, esophageal cancer locates mainly middle third of the thoracic esophagus, means around here, and the tumor depth T2 to T3. And what about lymph node metastasis? I don't know exactly, but I think the left lower paratracheal, I think right here, right? Or and left gastric region, I think right here. This is a Japanese classification of esophageal cancer. And we divide the regional lymph node in the 3 groups, group 1, and group 2, and group 3. And when we perform surgery esophagectomy for advanced esophageal cancer, we usually dissect D3 lymph node dissection. It means dissect group 1, group 2, and group 3. Here is a standard treatment strategy for synchronous locoregional double cancer of the oral cavity and thoracic esophagus. For locoregional oral cavity cancer, primary surgical resection and reconstruction is recommended. Then, if the patient is high risk, it means multiple lymph node metastasis, surgical margin, positive for surgical margin, extranodal involvement, post-operative chemoradiation should be done. On the other hand, for locoregional esophageal cancer, as I mentioned, neoadjuvant chemotherapy followed by surgery recommended. When we consider the treatment strategy for this patient, First, we have to decide the one-stage operation or two-stage operation. For this first question, I should answer two-stage operation because simultaneous operation is too invasive for patient. Long time it takes too long time. And how about order of treatment? Tongue cancer first, then followed by esophageal cancer, or esophageal cancer first and then tongue cancer. We will choose tongue cancer first and then esophageal cancer. After 2 or 3 weeks from surgery for tongue cancer, we will be able to perform neoadjuvant chemotherapy for esophageal cancer. We usually perform 2 courses of neoadjuvant chemotherapy using cisplatin and 5-FU. It takes 3 weeks for 1 course of chemotherapy, so that totally 6 weeks is necessary for complete 2 courses of chemotherapy. After that, surgery for esophageal cancer will be done. On the other hand, if we choose esophageal cancer first, it will take almost 12 weeks to start, to do surgery for tongue cancer. Then neoadjuvant chemotherapy for esophageal cancer might be effective for tongue cancer. There is a possibility that tongue cancer might progress, thus leading to be difficult for resection. This is last slide. It would be necessary to decide the priority of treatment when considering the treatment for double cancer. When we are choosing the sequential treatment for double cancer, it is important to keep considering the curability of the other cancer. Thank you.